Emergency front of neck access eFONA when intubation fails. Why emergency front of neck access eFONA is done when intubation fails. eFONA is done because the patient is in a can't intubate, can't oxygenate situation. All attempts to intubate have failed. Direct, video laryngoscopy, and other airway devices could not get a tube into the trachea. Mask ventilation and other oxygenation methods are not working. You cannot deliver oxygen with a bag and mask, LMA, or other supraglottic airway. The patient is running out of oxygen. Oxygen levels are dropping fast and brain-heart damage can start in minutes. Time is critical. It is the only way to get oxygen into the lungs immediately. By going directly the front of the neck into the trachea, you create a new airway path. It is a life-saving last resort. We only do it when everything else fails, because without oxygen the patient will not survive. Learning objectives. At the end of this presentation, participants should be able to 1. Define front of neck access eFONA. 2. Explain the indications for eFONA. 3. Recognize the can't intubate, can't oxygenate CICO situation. 4. Identify the anatomy of the cricothyroid membrane. 5. Describe different eFONA techniques. 6. Demonstrate the scalpel bougie tube technique. 7. Discuss equipment required. 8. Explain complications. 9. Review current airway guidelines. 10. Understand postoperative management. Introduction. 1. Airway failure remains one of the leading causes of anesthesia-related mortality. Losing the airway is still a top reason patients die during anesthesia. 2. Most difficult airways can be managed using advanced airway techniques. With tools, video laryngoscopy and supraglottic airways, we can handle most tough cases. 3. Occasionally, both intubation and oxygenation fail. Sometimes even backup methods do not work. You cannot tube and you cannot mask ventilate. 4. This creates a life-threatening emergency. This is called can't intubate, can't oxygenate. The patient has no way to get air. 5. Immediate oxygenation becomes the priority. At this point, getting oxygen in is more important than anything else. 6. Emergency front of neck access eFONA provides life-saving oxygenation. eFONA is cutting directly into the neck to create an airway and deliver oxygen right away. 7. Delay significantly increases morbidity and mortality. Every second counts. Waiting long leads to brain damage, cardiac arrest, and death. Research background. Studies show 1. CICO occurs in approximately 1 in 5,000–20,000 anesthetics. Can't intubate, can't oxygenate, is rare, but it does happen in anesthesia. 2. Mortality remains high and eFONA is delayed. If we wait too long to do emergency front of neck access, the chance of death goes up. 3. Early recognition improves survival. Spotting CICO quickly and acting fast saves lives. 4. Human factors contribute significantly to fear. Stress, poor communication, and hesitation are major reasons eFONA fails, not just technical skill. 5. Simulation training improves success rates. Practicing eFONA in drills helps teams act faster and more confidently in real emergencies. Definition. 1. According to Difficult Airway Society, eFONA is an emergency airway created through the cricothyroid membrane when conventional airway techniques fail. DOS defines it as cutting through the soft spot in the neck to get oxygen in when intubation and other methods do not work. 2. According to the American Society of Anesthesiologists (ASA), a life-saving rescue airway procedure indicated during a CICO emergency. ASA calls it the final rescue option. It is used only in can't intubate, can't oxygenate situations to save a life. 3. According to the World Federation of Societies of Anesthesiologists WFSA, the definitive emergency airway below the level of upper airway obstruction. WFSA describes it as the last option that goes below the blockage in the upper airway to secure breathing. Other names. 1. Emergency surgical airway. A general term for any surgical method used to create an airway during an emergency. 2. Cricothyrotomy. The procedure of making an opening through the cricothyroid membrane to allow breathing. 3. Cricothyrotomy. Another spelling for cricothyrotomy. Means the same thing, cutting into the cricothyroid membrane. 4. Surgical cricothyrotomy. Emphasizes that it is a surgical technique done with a scalpel, not needle-based. 5. Front of airway. Describes the location. The airway is made through the front of the neck. 6. Rescue airway. Called this because it is the last option used to rescue a patient when all else fails. 7. Emergency airway access. Highlights that it provides immediate access to the airway in an emergency. Historical background. 1. Surgical airway described centuries ago. The idea of creating an airway through the neck has been written about for hundreds of years. 2. Initially tracheostomy was commonly used. The first emergency surgical airway performed was a tracheostomy, cutting lower in the trachea. 3. Cricothyrotomy later became preferred due to doctors switched to cricothyrotomy because it worked better in emergencies. 1. Faster. It can be done in seconds, which is critical when the patient has no oxygen. 2. Easier. The anatomy is simpler to find, so it is quicker to learn and perform. 3. Less bleeding. The cricothyroid membrane has fewer large blood vessels, so there is less blood loss. 4. Lower complication rate. It causes few long-term problems compared to a tracheostomy in an emergency. 4. Modern difficult airway guidelines emphasize early eFONA. Current guidelines now say do not wait. If it is a CICO situation, perform eFONA early to save lives. Relevant airway anatomy. Important structures. 1. Thyroid cartilage. The large, Adam's apple, in the front of the neck. It is the main landmark used to find the airway. 2. Cricothyroid membrane. The soft, thin area between the thyroid and cricoid cartilage. This is where the incision is made. 3. Cricoid cartilage. The firm ring below the thyroid cartilage. It sits right under the membrane and helps you locate it. 4. Trachea. The windpipe. Once you enter the membrane, the tube goes into the trachea to deliver oxygen. 5. Thyroid gland. A gland that sits lower in the neck. You avoid cutting too low to prevent bleeding. 6. Carotid arteries. Major blood vessels on both sides of the neck. Stay in the midline to avoid hitting them. 7. Inferior jugular veins. Small veins in the front of the neck. They can bleed if you go off the midline. Target. Cricothyroid membrane. This is the exact spot for eFONA. It is safe, quick to access, and has minimal bleeding. Cricothyroid membrane. Characteristics. 1. Located between thyroid and cricoid cartilage. It is the soft spot right in the midline between the Adam's apple and the ring below it. 2. Approximately. It is a small but consistent area in most adults. 1. 9 mm high. About the width of a finger. Tall enough for a safe incision. 2. 30 mm wide. Wide enough to easily identify and cut into in an emergency. 3. Superficial. It lies just under the skin. You do not have to go deep to reach it. 4. Poorly vascularized. It has very few blood vessels. This means less bleeding when you cut it. 5. Easy surgical access. Because it is superficial and clear, it can be found and opened quickly even under stress. What is CICO? CICO equals can't intubate, can't oxygenate. Patient cannot be 1. Intubated. You cannot pass a breathing tube into the trachea through the mouth. 2. Ventilated. Bag mask or other devices cannot push into the lungs. 3. Oxygenated. The patient's blood oxygen level keeps dropping despite all attempts. Result. 1. Rapid desaturation. Oxygen levels in the blood fall very fast. 2. Severe hypoxia. The body and brain are not getting enough oxygen. 3. Cardiac arrest. The heart can stop because of lack of oxygen. 4. Death. Without oxygen, the patient will die within minutes. Immediate eFONA required. Asterisk. This is the trigger to cut through the cricothyroid vein right away to save the patient's life. Causes of CICO. 1. Airway obstruction. Anything blocking airflow like swelling, mucus, or secretions in the throat. 2. Trauma. Injury to the neck or face that damages or collapses the airway. 3. Laryngospasm. Vocal cords suddenly clamp shut and will not open, so no air can pass. 4. Massive facial injuries. Severe damage to the face makes it impossible to see or intubate, and also blocks ventilation. 5. Neck hematoma. A large collection of blood in the neck that presses on and squeezes the airway closed. 6. Tumors. Growths in the throat or larynx that block the passage for air and tubes. 7. Airway edema. Swelling of the airway tissues, often from allergic reaction or infection, narrowing the airway. 8. Burns. Inhalation burns cause swelling and scarring that block the airway. 9. Foreign body. Food, teeth, or objects stuck in the airway that cannot be removed quickly. 10. Congenital abnormalities. Birth defects that make the airway small, distant, or difficult to access. Indications for eFONA. 1. Failure of mask ventilation. You cannot get air into the lungs with a bag and mask even with good technique. 2. Failure of supraglottic airway. Devices like LMAs or iGels cannot maintain oxygenation or ventilation. 3. Failed intubation. Multiple attempts to put a breathing tube in have failed and there is no time left. 4. Cannot oxygenate. Oxygen levels keep dropping despite all other airway attempts. This is CICO. 5. Upper airway obstruction. The throat is blocked above the cricothyroid membrane and cannot be cleared. 6. Massive facial trauma. Severe face injuries make mouth intubation and mask ventilation impossible. 7. Severe airway edema. Extreme swelling from allergy, infection, or burns closes the airway. 8. Laryngeal injury. Damage to the voice box from trauma makes normal intubation unsafe or impossible. 9. Foreign body obstruction. Something is stuck in the airway and cannot be removed, so you go below it. 10. Anaphylaxis. Severe allergic reaction causes rapid airway swelling that blocks all other options. Difficult airway algorithm. 1. Plan A. Tracheal intubation. First attempt to place a breathing tube directly into the trachea. This is the standard goal. 2. Plan B. Supraglottic airway. If intubation fails, insert a device like LMA gel that sits above the vocal cords to ventilate. 3. Plan C. Face mask ventilation. If that fails, go back to bag and mask. If possible, wake the patient up so they breathe on their own. 4. Plan D. Emergency front of neck access eFONA. Last resort. When you cannot intubate and cannot oxygenate, cut through the cricothyroid membrane to get oxygen in immediately. When should eFONA be performed? Note: do not wait until cardiac arrest. Perform when 1. Oxygen saturation continues to fall. The patient's blood oxygen keeps dropping despite giving oxygen. Waiting makes it worse. 2. Face mask ventilation impossible. You cannot get air in with a bag and mask, even with good technique. 3. Supraglottic airway unsuccessful. Devices like LMA or iGel fail to oxygenate or ventilate the patient. 4. Intubation unsuccessful. You tried to put a breathing tube in but failed and have no more attempts left. 5. CICO declared. The patient is in a can't intubate, can't oxygenate situation. This is the trigger to do eFONA immediately. Recognizing CICO early. 1. Warning signs. Early clues like swelling, trauma, or difficult anatomy that suggest airway problems are coming. 2. Repeated failed attempts. Multiple tries at intubation or ventilation are not working and wasting time. 3. Falling oxygen saturation. The patient's oxygen level keeps dropping despite giving oxygen. 4. Unable to ventilate. Bag mask, LMA, or other devices cannot get air into the lungs. 5. Unable to intubate. You cannot pass a breathing tube into the trachea after several attempts. 6. Increasing airway trauma. More attempts cause bleeding and swelling, making the airway even harder to manage. 7. Poor capnography. The CO2 waveform is flat or weak, meaning little to no air is getting in and out. 8. Bradycardia. Heart rate drops because the brain and body are not getting enough oxygen. Types of front of neck access. 1. Needle cricothyrotomy. A large needle is poked through the cricothyroid membrane. Quick for oxygen but only a temporary fix. 2. Surgical cricothyrotomy. A scalpel is used to make an open cut in the membrane and a tube is placed. This is the fastest and most reliable method. 3. Percutaneous cricothyrotomy. A needle and wire technique is used to dilate the opening and place a tube. Done through the skin without a large cut. 4. Commercial cricothyrotomy kits. Pre-packaged with all the tools needed to do a cricothyrotomy quickly and in a standardized way. Needle cricothyrotomy. 1. Uses. Large bore cannula. A large needle or catheter is placed through the cricothyroid membrane to deliver oxygen in an emergency. 2. Advantages. Quick. It can be performed very fast when you cannot intubate or ventilate. 3. Advantages. Less invasive. Only a needle puncture is needed, no surgical incision. 4. Disadvantages. Kinking. The small cannula can bend and block the airway. 5. Disadvantages. Dislodgement. The needle can easily out of position. 6. Disadvantages. Poor ventilation. It provides oxygen but does not move enough air to ventilate properly. 7. Disadvantages. CO2 retention. Because ventilation is poor, carbon dioxide builds up in the blood. 8. Disadvantages. Temporary measure only. It buys you time but must be changed to a definitive airway quickly. Surgical cricothyrotomy. 1. Gold standard in adults. This is the most recommended method for front of neck access in adult patients. 2. Advantages. Rapid. It can be done quickly in a CICO emergency. 3. Advantages. Reliable. Once placed, the airway stays open and works consistently. 4. Advantages. High success. Has a very good success rate when performed correctly. 5. Advantages. Better ventilation. Allows proper movement of air in and out, on needle methods. 6. Advantages. Lower failure rate. Less likely to kink, block, or fall out compared to other techniques. 7. Preferred by major airway guidelines. Major emergency and anesthesia guidelines recommend this is first for CICO. Scalpel bougie tube technique. Recommended by 1. Difficult Airway Society (DAS). The main UK group for airway management endorses this as the technique of choice. 2. Many international airway societies. Other major airway organizations worldwide also recommend this method. Steps. 1. Identify membrane. Feel for the cricothyroid membrane in the front of the neck. 2. Vertical skin incision. Make a quick vertical cut through the skin to expose the membrane. 3. Horizontal membrane incision. Cut horizontally across the cricothyroid membrane to open the airway. 4. Insert bougie. Pass a bougie, a thin guiding tube, into the trachea through the opening. 5. Railroad 6.0 cuffed tube. Slide a size 6.0 cuff tube over the bougie and into the trachea. 6. Inflate cuff. Blow up the cuff on the tube to seal the airway and prevent leaks. 7. Confirm ETCO2. Check end tidal CO2 to make sure the tube is in the trachea and not the esophagus. Step-by-step procedure. 1. Call for help. Get more staff immediately. You will need assistance for drugs, equipment, and documentation. 2. Declare CICO. State out loud that it is, can't intubate, can't oxygenate, so the team goes to switch to front of neck access. 3. Extend neck if possible. Tilt the head back to make the cricothyroid membrane easier to feel and cut. 4. Palpate membrane. Use your fingers to find and hold the cricothyroid membrane in the middle of the neck. 5. Vertical incision. Make a vertical cut through the skin down to the membrane. This is safer and bleeds less. 6. Horizontal stab incision. Make a horizontal cut through the cricothyroid membrane to open the airway. 7. Rotate scalpel. Turn the blade 90 degrees to widen the opening for the tube. 8. Insert bougie. Pass a bougie through the opening into the trachea as a guide. 9. Railroad tube. Slide a cuffed tube over the bougie and into the trachea. 10. Inflate cuff. Inflate the cuff on the tube to seal the airway and stop air leaks. 11. Confirm ETCO2. Check for a CO2 waveform to confirm the tube is in the trachea, not the stomach. 12. Secure tube. Tie or tape the tube in place so it does not move or come out. Required equipment. 1. Scalpel number 10 or 11. Used to make the vertical skin incision and horizontal membrane cut. 2. Bougie. A stiff guide that goes into the trachea first, then the tube slides over it. 3. Asterisk 6.0 Cuffed endotracheal tube. The tube that is placed into the airway to deliver oxygen and seal it. 4. Suction. Clears blood, secretions, or vomit from the airway so you can see and ventilate. 5. Syringe. Used to inflate the cuff on the endotracheal. 6. Capnography. Confirms the tube is in the trachea by detecting exhaled CO2. 7. Tape. Secures the tube in place so it does not move or come out. 8. Gloves. For sterile technique and to protect you during the procedure. 9. Antiseptic. Cleans the skin before making the incision to reduce infection risk. 10. Oxygen source. Provides oxygen to ventilate the patient once the tube is in place. Confirmation of placement. 1. Continuous capnography, gold standard. The most reliable way. A CO2 waveform proves the tube is in the trachea. 2. Chest rise. Watch the chest go up and down with each breath to show air is going in. Equal breath sounds. Listen on both sides of the chest to confirm air is reaching both lungs. 4. Improved oxygen saturation. The SpO2 on the monitor should go up if the tube is working. 5. Tube misting. See condensation or fog inside the tube with each exhale. 6. No gastric insufflation. The stomach should not be blowing up, which would mean air is going to the gut. Complications. 1. Bleeding. Blood vessels in the neck can be cut during the incision. 2. False passage. The tube or bougie goes into tissue instead of the trachea. 3. Esophageal injury. The food pipe behind the trachea can be damaged if the cut goes deep. 4. Tube displacement. The tube can come out or move, causing loss of the airway. 5. Subcutaneous emphysema. Air leaks into the tissue under the skin and causes swelling. 6. Pneumothorax. Air leaks into the chest cavity and laps a lung. 7. Infection. Bacteria can enter through the incision site. 8. Voice changes. Damage to the larynx can affect voice quality long-term. 9. Tracheal injury. The trachea itself can be cut, torn, or damaged. 10. Death. The most severe outcome if the airway cannot be secured in time. Contraindication. 1. No absolute contraindication during CICO. In a can't intubate, can't oxygenate emergency, you proceed anyway because saving life comes first. 2. Relative contraindications. These make the procedure hard or riskier, but may still be done if no other option exists. 3. Children. The anatomy is very small and fragile, so risk of damage is higher. 4. Laryngeal fracture. A broken larynx means the normal landmarks are destroyed and cutting there is dangerous. 5. Neck tumors. Masses can distort anatomy and increase bleeding risk. 6. Distorted anatomy. Trauma, swelling, or congenital issues make it hard to find the membrane. 7. Previous neck surgery. Scar tissue can make landmarks difficult to identify and increase complications. Pediatric considerations. 1. Children have. Small bodies mean everything in the airway is smaller and closer together. Procedures must be done with extra care. 2. Small membrane. The cricothyroid membrane is tiny in kids. It makes it hard to locate and increases risk during surgical airway. 3. Soft cartilage. A child's trachea and larynx cartilage is softer. It can collapse easily if too much pressure is applied. 4. Higher airway. The larynx sits higher in the neck in children. Landmarks in different positions compared to adults. 5. Greater complication risk. Bleeding, damage, and failure rates are higher in children because of their small size and delicate tissues. 6. Needle techniques may be considered in younger children, depending on local protocols and expertise. Asterisk. For very young kids, a needle cricothyrotomy is often safer than a surgical one. Use it only if your protocol and training allow it. Human factors. 1. Communication failure. When team members don't speak clearly or don't share information. This leads to mistakes and delays in emergencies. 2. Poor teamwork. When the team doesn't work together, assign roles, or support each other. This causes confusion and missed steps. 3. Delayed decision-making. Waiting too long to act or decide. In critical airway situations, delay can make things worse very fast. 4. Stress. High pressure affects thinking, memory, and performance. Stress can make people forget protocols or panic. 5. Fixation error. Focusing only on one problem and ignoring other solutions. Example: keep trying intubation instead of moving to plan B6. Repeated intubation attempts. Trying to intubate over and over. This causes trauma, swelling, and makes the airway harder to manage. 7. Failure to declare CICO. CICO means, can't intubate, can't oxygenate. Not calling it out early delays life-saving surgical airway. Airway guidelines. Major recommendations. 1. Recognize CICO early. CICO means can't intubate, can't oxygenate. Spot it fast so you don't waste time and can move to a life-saving airway. 2. Limit intubation attempts. Too many tries cause swelling and trauma. Stick to a set number, then move to your next plan. 3. Call for help immediately. Don't wait. Get senior airway help and extra hands in the room as soon as things look difficult. 4. Use scalpel bougie tube technique in adults. This is the recommended surgical airway method for adults in CICO. It's fast, simple, and effective. 5. Confirm placement with capnography. After placing a tube, use capnography to prove it's in the trachea and the patient is getting CO2 out. 6. Regular simulation training. Practice these scenarios often. Training builds confidence, speed, and teamwork so you act right under pressure. Post-eFONA management. 1. Secure airway. Make sure the emergency airway is stable and not dislodged. Check tube position and cuff to keep oxygen flowing. 2. Mechanical ventilation. Connect to a ventilator to support breathing and oxygenation while the patient recovers. 3. ICU admission. Move to ICU for close monitoring, sedation, and management of complications. 4. Chest X-ray. Confirm correct tube placement and check for complications like pneumothorax or tube misplacement. 5. Definitive tracheostomy if needed. If long-term airway support is required, convert the emergency airway to a formal surgical tracheostomy. 6. Treat underlying cause. Address what led to eFONA in the first place, like swelling, trauma, or abduction, to prevent recurrence. 7. Documentation. Record the event clearly. Note timing, attempts, who was involved, and decisions made for legal and clinical review. 8. Debrief team. Sit with the team after. Discuss what went well, to improve, and support each other emotionally. Nursing, anesthesia responsibilities. 1. Prepare airway equipment. Check and set out all airway tools before the procedure. Laryngoscope, bougie, suction, and emergency airway kit must be ready. 2. Monitor oxygenation. Watch PO2 and capnography closely. Alert the team early if oxygen levels drop. 3. Assist during procedure. Pass instruments, apply cricoid pressure, and support positioning to help the airway operator work smoothly. 4. Administer drugs. Induction agents, muscle relaxants, and emergency drugs as ordered, with correct doses and timing. 5. Maintain sterility. Keep the field clean. Use sterile technique for intubation and surgical airway to reduce infection risk. 6. Confirm tube plate. Help verify the tube is in the trachea using capnography, auscultation, and chest rise. 7. Continuous monitoring. Track vitals, airway pressures, and patient response throughout. Catch problems early. 8. Prepare ICU transfer. Set up ventilator, monitors, and handover notes so the patient moves safely to ICU after. 9. Documentation. Record everything. Airway assessment, attempts, drugs given, complications, and who was present. Prevention of CICO. CICO equals can't intubate, can't oxygenate. 1. Adequate airway assessment. Check the patient thoroughly before induction. Look for predictors of a difficult airway so you can plan ahead. 2. Prepare difficult airway equipment. Have backup tools ready before you start. Video laryngoscope, bougie, supraglottic airway, and surgical airway kit should be in the room. 3. Use airway algorithms. Follow a clear step-by-step plan. Algorithms keep the team focused and prevent panic in a crisis. 4. Optimize positioning. Put the patient in the best position for intubation. Sniffing position, ramping, and head elevation improve your view and success rate. 5. Limit attempts. Don't keep trying the same failed method. Multiple attempts cause trauma and swelling. Move to Plan B early. 6. Call for help early. Get senior and anesthesia help at the first sign of trouble. Don't wait until oxygen is failing. 7. Regular simulation training. Practice CICO scenarios often. Training speed, confidence, and teamwork so you act right under pressure. Advantages of eFONA. eFONA equals emergency front of neck airway. 1. Rapid oxygenation. Gets oxygen into the lungs fast when all other methods have failed. Saves critical minutes in a CICO situation. 2. Life-saving. It is the last resort that prevents brain damage and death when you can't intubate and can't oxygenate. 3. Simple equipment. Needs only a scalpel, bougie, and tube. No complex machines required, so it can be done quickly. 4. High success. The scalpel bougie technique has a very high success rate when performed correctly and quickly. 5. Recommended worldwide. Major airway guidelines and societies across the world list it as the standard rescue technique for CICO in adults. 6. Definitive rescue airway. Provides a secure, definitive airway that can be used for ventilation and later converted to a tracheostomy if needed. Limitations. 1. Requires training. You can't do it well without practice. Proper training is needed to perform eFONA safely and quickly. 2. Stressful. It happens in a life or death CICO situation. The high pressure can affect decision-making and performance. 3. Complications possible. Risks include bleeding, infection, false passage, and damage to nearby structures like thyroid or vessels. 4. Poor landmark identification in obesity. Excess neck tissue makes it hard to feel the cricothyroid membrane. This delays the procedure and increases risk. 5. Rare procedure. Most clinicians may never do one in real life. Because it's uncommon, people may hesitate or lack confidence. 6. Loss of skills without practice. If you don't practice regularly, the steps and speed are forgotten. Simulation helps keep skills sharp. Key messages. 1. Oxygenation is the priority. Keeping oxygen in the patient is more important than intubation. If oxygen is failing, act fast. 2. Recognize CICO early. CICO means can't intubate, can't oxygenate. Spot it early so you don't waste time on methods that aren't working. 3. Avoid repeated intubation attempts. Too many tries cause swelling and trauma. Stop after a set number and move to your next plan. 4. Declare CICO without delay. Say it out loud to the team. CICO early triggers help and moves you to a rescue airway faster. 5. Perform eFONA promptly. eFONA is emergency front of neck airway. Do it without hesitation when indicated. Delay costs lives. 6. Scalpel bougie tube is the preferred adult technique. This is the fastest and most reliable surgical airway method recommended for adults in CICO. 7. Confirm placement with capnography. Always check CO2 to prove the tube is in the trachea and the patient is being ventilated. 8. Practice regularly through simulation. Train often so the team stays confident, fast, and coordinated when a real CICO happens. Summary. 1. eFONA is the final rescue step in difficult airway management. It is used when all other airway methods have failed. The last option to save the patient's life. 2. It is indicated in a can't intubate, can't oxygenate CICO emergency. When you cannot get a tube in and the patient is not getting oxygen, eFONA must be done immediately. 3. Early decision-making saves lives. Don't wait too long. Recognize CICO fast and act. Delay increases risk of brain injury and death. 4. Circle cricothyrotomy using the scalpel bougie tube technique is the recommended approach for adults. This method is fast, simple, and proven. It is the standard technique taught in major airway guidelines. 5. Team communication, preparation, and regular simulation training are essential for successful outcomes. Clear roles, ready equipment, and practice together. This builds confidence and speed in a real emergency. Take-home tips. 1. Oxygenation is the priority, not intubation. The goal is to get oxygen in. Don't get stuck trying to intubate if the patient is desaturating. 2. Recognize CICO early. CICO equals can't intubate, can't oxygenate. Spot it fast so you can switch to rescue plans. 3. Limit repeated intubation attempts. Too many tries cause airway trauma and swelling. Move on after 2 to 3 attempts max. 4. Declare CICO clearly. Say, CICO, out loud. This alerts the whole team and triggers the emergency airway pathway. 5. Call for help immediately. Get senior anesthesia, and extra hands in the room early. Don't manage it alone. 6. Perform eFONA without unnecessary delay. eFONA equals emergency front of neck airway. When indicated, do it now. Time is critical. 7. Use the scalpel bougie tube technique in adults. This is the fastest and most recommended surgical airway method for adults in CICO. 8. Always confirm placement with continuous capnography. CO2 tracing proves the tube is in the trachea and ventilation is working. 9. Practice regularly using simulation. Drill the steps often so you stay fast, calm, and coordinated in a real emergency. 10. Every anesthetist should be competent eFONA. It's a core skill. You must know it because CICO can happen to anyone, anytime. Professional quote. 1. The decision to perform emergency front of neck access is not a failure of airway management, it is the successful execution of the final life-saving step in a well-planned difficult airway strategy. Doing eFONA means you followed the plan. It's not giving up, it's saving the patient when other options are gone. 2. In airway emergencies, seconds save brains, and decisive action saves lives. Oxygen loss damages the brain fast. Acting quickly and confidently in a CICO situation prevents harm and death. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.